No lo presento porque ya lo presentamos tantas veces, ya inició el módulo, así que ya lo conocen todos. Muchas gracias, doctor.
Okay. All right. I think we're all getting a little bit tired. Well, things are certainly very dynamic in the world of haemophilia treatment. And in this last talk, I will try, with a lot of information, to go over the new treatments which are not so much emerging as have emerged and will continue to emerge over the next few years, and discuss some of the principles which perhaps should guide us in actually exploiting and using these new therapies. Okay. All right. Again, to reiterate the problems that we have in hemophilia, at least in the countries which can afford to treat, we've got the question of conversion of patients whenever it's appropriate to prophylaxis. This is influenced by costs. It's more expensive. We've discussed the question of cost effectiveness, but it's also influenced by the question of adherence, because although it is definitely beneficial in many patients, it is not easy to have a life whereby every couple of days or every 3 days you have to actually infuse yourself, and this is particularly difficult in children. Then there's the question of inhibitors, which we have gone into very thoroughly in this conference, whether we treat or we tolerize, and again this is influenced by costs. So, having outlined the basic landscape against which these treatments were developed, let us now look at what has actually been achieved. And it is a remarkable story, because when I think about the fact that when I started my career 30 years and more ago, we were limited to maybe 4 or 5 different factor concentrates, and when I think about the fact that even in the rich countries, a huge amount, a substantial proportion of patients were still on crab precipitate, we really have made huge advances in terms of understanding the science and allowing us to develop new products. So there are two basic classes of products I'm going to talk to you about today. The first class is based on the traditional principle of replacing the missing coagulation factor. And there are several new technologies, mostly around the longer-acting products, around the concept that we alter the recombinant molecules. These have all been made possible by recombinant technology. There is no doubt that we cannot envisage these kinds of developments by modifying plasma-derived factor VIII. It's not practical. But certainly, the generation of longer-acting products is made possible by altering the gene structure of the recombinant cell lines. Cell lines themselves are a source of research interest, and we have the traditional cell lines which generate the products from mice and other rodents, like guinea pigs and hamsters and so on. But we also have human cell lines now which generate factor VIII. These are of interest because of various possible advantages. So those are the therapies based on traditional principles. Then we have, very interestingly, over the past 3 years or so, the sudden appearance of a number of alternative pharmacological approaches not based on traditional replacement of the missing factor, but based upon principles somewhat similar to the bypassing agents for treating inhibitors in relation to bypassing the action of factor VIII, and also in the manipulation of the thrombotic pathways of normal hemostasis in order to achieve the same aim. Excuse me again while I get myself some water. Yep, my voice is starting to give out. Okay, very good. So let's talk a bit now about the so-called half-life extension products. This is the most active area of involvement and development, and where in fact we now already have products on the market. We have the so-called fusion technology products, in which the recombinant factor VIII molecule, as a result of its manufacture in the cell line, is fused, is joined to other types and fragments of molecules in order to affect the pharmacokinetics. And of these, we currently have two main types of technologies: FC fusion, in which the product is fused to the FC part of the immunoglobulin molecule; albumin fusion, in which recombinant albumin itself is joined to the coagulation factor recombinant product. There is this technology called CTP fusion, in which the actual C part of the human growth hormone is fused to the molecule, again for the same purpose. I'm not going to talk about this because there are no real products yet. There is some indication in the literature, mostly through abstract. So I don't think it's well advanced, and we don't have the time to look at everything. Here are the actual products which we see over here, and these first products are all B-domain deleted and are produced in a traditional hamster kidney cell line. So you've got factor VIII FC, factor IX FC, factor VIII FP with albumin and so on. Then we've got the pegylation technology, in which PEG, polyethylene glycol, is joined to the molecule. I will show you how this is done, and we have these types of products as well. All the big companies which traditionally supply factor VIII recombinant are involved in these developments to a greater or lesser extent. Here are the main principles involved in FC fusion. Here you can see the factor VIII molecule itself, and you can see that at the C2 terminal we have joined FC receptors, the FC part of the immunoglobulin molecule. Rather, this is intriguingly the albumin fusion product related to recombinant albumin, and intriguingly I say, because in this particular illustration it is joined, as you may see, to the structure of von Willebrand factor. And this might be quite interesting to reflect upon in a few minutes. In pegylation, we have these different types of chemistry: site-directed pegylation of the recombinant factor VIII, random pegylation, and glycopegylation. And we have both, in terms of the products being generated by Novo Nordisk, a factor VIII product as well as a factor IX product, and in fact the factor IX product is significantly more advanced. In terms of the mechanism of half-life extension by PEG, this is subdividable into various parts of mechanisms. You can see that there's a decrease in glomerular filtration, simply because the molecule is made bigger. There is a receptor-mediated clearance of PEG, and this is inhibited by attaching the PEG to the activated to the clotting factors. And then there is a decrease in proteolytic degradation of polyethylene attached clotting factor molecules. All this is shown on this slide. So we have various reasons why molecularly, by attaching this fairly simple and easily acquired molecule, we can get a difference in the pharmacokinetics. This is the state of play. This is a summary of the situation at the moment in terms of what is actually underway and available. Here you've got the factor VIII products, here the factor IX products, the various differences, the principles involved, whether it's pegylation, which is for most of the factor VIIIs. FC fusion by Biogen IDEC is also already approved, as is pegylation for the product manufactured by Baxter. The other two products from Bayer and Novo are underway in phase 3 clinical trials, so we must expect to have approval pretty soon. And for the factor IX, the most advanced situation is the FC fusion product for Biogen IDEC has been on the market now for more than 1 year. The albumin fusion product, marketed and developed by CSL, was approved earlier this year by the FDA, and we now have the completion, and I think very well published and pretty soon to be approved, product from Novo 7 with the site-directed glycopegylation. Also shown on this slide, and we're going to look at this in much more detail, is the improvement in pharmacokinetics, the improvement in half-lives observed. And one interesting point which I point out to you is that observe that if we look at the factor 9s, where the situation is much more advanced, the first product has a half-life extension of about 3 to 5 times the standard product. The second product, approved a little after, is already better in terms of 5 times. And I have seen the work, was also reported in Orlando in July at the WFH meeting, of the pegylated product from Novo Nordisk, already 6 times the half-life. So we have an interesting situation here. We have a situation whereby the technology is really rushing ahead, and the competition between the companies is making what seemed to be a wonderful product just 2 years ago start looking a bit redundant. The Biogen product, which is, slowly gaining acceptance in the United States market primarily, has been outstripped in terms of its properties by the CSL albumin fusion, which in its turn is going to be edged out a bit by the product from Novo Nordisk. Wonderful competition. I haven't said much about the factor 8s in this. Well, why? Let us look at, therefore, the situation with factor 8s. These are the various types of products. All of these are pegylation, Bayer, Baxter, and Novo. And the factor 8 FC is the FC fusion product of CSL. This product and this product are approved. Observe here the extensions in half-lives of these various products. There is an extension. It is nowhere as large as the extension achieved in terms of the factor 9. In fact, in this summary, which is perhaps much easier as a very clear representation of the situation, you can see that the increase in the half-life, the ratio to the standard molecule which has not been modified, is about 40 to 50 or 60%. There is an increase, but it's not much. It's not much. Why is this? Well, it's very clear why this is. Factor 8 does not exist. There's no such thing as factor 8 in the body. Factor 8 depends on the circulatory properties through its binding to von Willebrand factor, and therefore the kinetics inside the body after infusion of a recombinant factor 8 without von Willebrand factor will be practically totally dominated by the binding of the factor 8 to the von Willebrand factor inside the patient, which is not modified and still has the standard pharmacokinetic properties that it had before. So the question in my mind is not why the factor 8 products don't have an extended half-life, but why do they? I am actually mystified as to why actually these half-lives are claimed. And I have some suspicion that actually there is no increase in half-life at all. And because the science of pharmacokinetic calculation of coagulation factors keeps advancing, and we see some interesting manipulations in the calculations. Be that as it may, it is possible that we will have a longer-acting factor 8 with a longer-acting von Willebrand factor. And here we see the possibility. Yesterday I showed you a kind of variation of this slide to explain the mechanism whereby von Willebrand factor protects factor 8. And if we had a von Willebrand factor, in this instance with the D' D3 region joined to the FC portion for an FC fusion type product, joining this to the FC factor 8 fusion product should lead us to expect to an increased half-life through the same mechanism that we get for the other fusion proteins. So at the moment we do not have this large increase in half-life. These products are efficacious. They do, of course, decrease and are very efficient in decreasing bleeding in haemophilia. They are as efficient, more or less, as standard recombinant products. I draw your attention here to the data which is summarized on this slide. There is some interesting points to be made here. So here is the mean annualized bleeding rate for prophylaxis, which is what these developments are all about. These the pressure, the thrust behind the development of extended half-life products is in fact to improve compliance in patients on prophylaxis. Patients, especially young patients, don't like to have to take injections every 2 or 3 days. Therefore, by extending the half-lives, we can decrease the infusion frequency and hopefully increase compliance. But you can see that if you look at the actual annualized bleeding rates, this on a twice-weekly regimen and these on once-weekly regimens, well, we are nowhere near the 0 to 1 level which we actually expect on the basis of experience with good prophylactic regimens with the standard products. I make this point because it is my belief that effectively for the extended half-life factor rates at the moment, there has been a lot of marketing in order to persuade people that we can actually decrease infusion frequency. I do not believe that the current state of development of these products allows this to be done to the same extent that the companies which have developed them are claiming it. That is a subjective opinion, but perhaps people would like to challenge or discuss it. Let's now talk about something immensely different. We haven't said much about factor IX and haemophilia B at this conference, but now we must. And here are the pharmacokinetic properties of extended half-life recombinant factor VIIIs. The FC fusion product of Biogen, the albumin fusion product of CSL, and the pegylated product of Novo Nordisk. And observe the point which we have already seen in the previous preliminary slide, that we get very nice extensions in the half-life. And in the next product we get an even bigger extension. And now observe the huge extension in half-life which we get with the most recent developed product. There is no doubt that the technologies are working very well, because factor IX does not depend on another protein for its circulatory half-life, and therefore we can expect that these molecular alterations will produce effectively increased and improved pharmacokinetic properties. And this is, of course, indeed the case. And again, I make the point that whereas with the FC fusion product of Biogen we got 2.5 times the half-life, CSL immediately made that look redundant with 4.2 times, and now nearly 5 times the standard half-life with the Novo Nordisk product. And this is absolutely wonderful, I think, for haemophilia B, in all honesty. Now let us look at the clinical data in terms of efficacy and observe what we have here. And this time we have much more data to go upon, so there are also ranges, but you can see with different types of regimens. If you look at the product information, what we call the product label, but it's actually on the label, it's in the leaflet in the package of the product, you will see that, for example, the Biogen product, the FC fusion product, recommends 2 different types of regimens with different types of dosages, and I shall discuss this in a few minutes in relation to the cost effectiveness of the 2 different types of therapeutic approaches. But you can see that we get ABRs, annualized bleeding rates, which are quite low overall. Sometimes we do not get exactly what we expect, and we get even breakthrough bleeds over the course of a year. Now, okay, this is not much, you might say. I mean, 3 bleeds per year, but I remind you that joint bleeding in haemophilia is a severe consequence even when it is at a low frequency, and in fact we know that there is the phenomenon of subclinical bleeding in the joints, in which radiological deterioration can be detected in the children even when they don't have overt hemarthrosis. And so we must expect that this level of annualized bleeding has under it, if you like, some level of subclinical bleeding into the joints, which can result in damage later on. And this is, I think, a problem, because it does lead us to think that maybe the whole question of extending the half-life and decreasing the infusion frequency is being, to some extent, overemphasized in order to market the new molecules as a way of increasing compliance with prophylaxis, whereas what we should be looking at perhaps is other aspects of the pharmacokinetics of the factors. Rather than thinking about the lower infusion rate, perhaps we should keep the same infusion rate and try to attain higher levels over the course of a standard treatment protocol. And we shall see some of this in later slides. So, in order to emphasize what I have just said, I'm going to show you some alternative scenarios in relation to prophylaxis with regards to the standard pharmacokinetic parameters. Now, you all know, this is the same situation for both factor 8 and factor 9, that we have certain types of parameters which we characterize the pharmacokinetics. So we have the peak level, what is attained after a certain dose, then depending on the actual half-life, we have this going down. The reduced bleeding risk zone is over until we reach the trough. Below the trough is the level where we conventionally consider to be a very high level of risk of spontaneous bleeds. And traditionally, since prophylaxis became reasonably established over the past 20 years, we have looked on the desirable trough level as being something like 1% of normal. In other words, the conversion of severe haemophilia to a somewhat moderate form. But remember, 1% isn't much. The current level of thinking is moving more towards 2 to 5%. And probably, as time goes by, this will be shifted upwards. So I'm going now to show you some possible scenarios. Let us consider, for example, a patient on a standard product. I want to emphasize one point. Much of what I'm going to tell you is equally applicable to the new products and to the old products. There's nothing special about the new products in terms of the principle, they just change the curve. Furthermore, much of what I'm going to tell you is also applicable to plasma-derived factor 8. You must not run away with the idea, which is constantly pushed, that this wonderful pharmacokinetic manipulation and management of patients is dependent only on recombinants. I remind you that prophylaxis was started in Sweden in the 1960s when we didn't even have a dream of recombinant factor 8. Now look at the situation here. So yeah, supposing we've got this child, okay, and this kid, and he's 6 years old, whatever, he goes to school, but then, you know, on the weekend he doesn't want to have an injection and so on, but with the standard situation here, we have, if this infusion is not repeated on Sunday, we're going to have a period where the child is clearly in a situation of substantial risk. To have this situation not happen, it is not really essential to actually have a different pharmacokinetic profile. If we had a different half-life here, we could envisage that this would cover the period. But instead of having a different half-life, we could simply elect to increase the dosage. Depending on the actual factor involved, we have to increase the dosage by a greater or lesser extent. And in this instance, actually, in order to have full cover with the same half-life, remember, we're talking about the same half-life here, but by increasing the dosage, we get this huge peak. And then we get cover over the whole period in terms of the trough level, but we have this huge peak. And of course, it may be clinically dangerous to subject the patient to a peak, which in this instance is something like 2 to 3 times the level of basic normal, even though this does not last for a long time. There is a literature on thrombosis in von Willebrand disease patients who have been given so-called excess amounts of plasma-derived factor 8 through von Willebrand factor. However, the point to be made is that we can attain it in this way. Let's look at another circumstance. These are so-called active patients again, and in order to perhaps have a situation of coverage over the weekend, the standard product with with infusion every 2 days is increased slightly in dosage so as to cover Saturday, but you can see that Sunday now we have dropped below the trough level, so we're in a kind of somewhat different and difficult situation. However, if we stick regularly to an infusion frequency of once every 2 days, this will be covered, but remember that we are in a somewhat vexatious situation, because it will mean, since there are 7 days in the week, if we give every 2 days, it will mean that every alternative Sunday we have a gap. So that will not help us if every fortnight at Sunday the kid wants to play football and he is without his factor A. What can we do? Well, we can look at a situation whereby actually on Sunday we give a smaller infusion, and this will give coverage for the trough level for just the Sunday without using as much factor VIII as with the standard regimen. What we can also do by being smart on pharmacokinetics is to give a much smaller dose, but to give daily infusions. This is actually done in Sweden. Many patients are on daily prophylaxis, which with much lower levels of factor VIII infused. Very economical way of doing it. Swedish children, I think, are much more disciplined than most children everywhere, because to take an infusion of factor VIII every day is, I think, substantially onerous. The point to be made, though, that by understanding the pharmacokinetics and understanding the individual patients, a child of 8 years old wanting to play football is different from a man in his 40s who works in front of a computer, who is different from an old person who perhaps sometimes likes to go for a bit of a walk, but otherwise is relatively sedentary in life. Again, the principle of personalizing the treatment. Here's now another interesting situation, because now we start considering what happens in relation to non-adherence and the situation involving a long half-life coagulation factor. So here is another standard product, infusion every couple of days, and the patient misses an infusion here. This is the trough level below which we can consider the patient is to be in some level of danger. So you can see if he misses his injection here, there's going to be a period of a couple of days in which he's going to be below that trough level and at great risk of developing bleeds. If he retains the regular infusion, we also get periods of time in which there is dropping of the factor level below the crucial trough. However, this conveniently, if we time the infusions appropriately, happens during the night, where hopefully he's not playing football or climbing mountains or running around on motorbikes. And therefore, this portion of risk is made less obvious because of the particular time in which it is being experienced. Let's look at the situation with a long half-life product. If you have a long half-life product and you say, okay, well, we infuse on Monday and we won't infuse for another Monday, we'll do a 7-day. I remind you that this was one of the label claims already on the products which we have. Depending on the dose, of course, after a few days we start moving into the zone of risk in relation to getting below the trough level. This is not a good situation. There is a substantial risk that we will have bleeding even here with these half-life extended products. It is very important to always understand the individual pharmacokinetics of the particular situation. And of course, all these developments have been made on the basis of the products, but very few thoughts have been put into, relatively, on the pharmacokinetics of the patients themselves. Because like everything else in life, pharmacokinetics to an infused product, irrespective of its properties, has a lot to do with the individual patient characteristics. And look what happens if you consider a 25% variation in half-life between 3 different patients. These are 3 different patients. They vary by 25% on either side of this patient here with relation to the half-life of the particular product. Observe what a remarkable effect this has in relation to what will happen to the trough levels vis-a-vis infusion frequency. Obviously, this patient here will drop below the trough quite after the reference patient compared again to this patient here. And here we develop the concept of personalized prophylaxis. I emphasize again, this doesn't depend on the presence of these new products. However, to be fair, it is the case that although great investigators like Morfini and Martinovic developed the discipline of pharmacokinetics of coagulation factors 40 years ago, it is in the past 5 years, under the stimulus of understanding what happens with these new products, that we have renewed our interest in these concepts. And it is important because when you do this, and this study, for example, this is a study looking at the recombinant FC product for factor VIII, the product which I told you really doesn't have much of an extension in the half-life. If you look at the mean ABR, the median ABR, with on-demand therapy, with this product, we get a median ABR of 18 bleeds a year. Once weekly prophylaxis gives us 3 bleeds a year, and that means we give once weekly prophylaxis to all the patients. The median will be 3 bleeds a year. But if we tailor the prophylaxis, study the individual patients, and depending on the individual patient half-life, we give less or more infusion frequencies. With some patients we have to give a higher infusion frequency, with others a lower one. We can actually achieve median ABRs which are lower. And this is the important point, to basically assess very carefully how we match the patient characteristics to the product characteristics, rather than to just read the label of the manufacturers, who are mostly interested in making sure that we consume a lot of their product. This is a very interesting paper, which is quite complex in terms of the data, but I am going to try and deliver to you the message. And because this paper looks at the peak level of factor VIII, which I remind you is not the half-life, but what is achieved immediately after infusion, and relates the peak level to the annualized bleeding rate in relation to pharmacokinetic guided personal prophylaxis. The point to be made here is mostly important in this slide, in which we have every dot here is a patient, okay? And then we use a computer program to generate median behavior in terms of this line here. But we can divide this body of data into 4 quadrants, and these are subdividable, as you can see here. Quadrant A are patients who have high annualized bleeding rates when they have low peak, and quadrant B are patients who have high annualized bleeding rates even when they have a high peak. Quadrant C, low annualized bleeding rate with a low peak. Quadrant D, low annualized bleeding rate with a high peak. By characterizing carefully these individual patients, we can then tailor the dosage. If you look, for example, at, of most interest here, are these patients in quadrant C. There are not that many of them, but there are a few. And these are patients who have low annualized bleeding rates, even when they have a low peak. And therefore, with these patients, we can dose at lower levels, knowing that the bleeding rate will not be as high. And in this way, we can conserve best the coagulation factor. And I emphasize you can do this for any product, irrespective, because what this depends on is not the product per se. It depends on particularly the characteristics of the patients. Very important principles. Here is a situation now comparing, again, the conventional factor IX, let's just say what it is, it's basically Benefix, to the longer-acting factor IX. In this instance, let's say that this is the Aprolix of Biogen. So if you infuse Benefix, you get the normal half-life, and then you have to infuse again. I mean, you've dropped below the trough of 1% here. You have to infuse again and again. But at the same time, by infusing, you are getting these high peaks. You are getting these, importantly, high levels of factor VIII, where you may or may not need them. Whereas if you infuse less frequently, in this instance it's a 10-day schedule with the longer-acting factor VIII, it's true that you've taken about 10 days to achieve the getting below the important 1% trough level, but never during these 10 days, have you had sufficient cover, for example, to deal with a major trauma? If the kid was riding his bike and he fell down and hit his head, he would have had to be, for sure, given another infusion, because this, what we call high peak level, is not achieved. So again, it depends on the individual patient and the individual circumstances. It's not as easy as these publicity materials will tell you that, you know, you've achieved longer half-life, you can easily give less infusions and less product, because this is how these products are being sold in relation to getting reimbursement. The argument is, if you have a longer half-life, you can give less product because lower infusion frequency. It's not necessarily the case. And let me make it clear, I'm very excited about these products. There's no doubt in my mind that in relation to the factor 9 situation, they have achieved a significant shift in the paradigm of therapeutics. But it's not as simple as people would like people to believe. Look at now the situation in terms of cost considerations. And this was presented by Dr. Neufeld from Boston. It is from a paper he wrote last year in Haemophilia, very good editorial, but it was also presented at the WFH. And here he's basically comparing the labels, which I told you about. He's comparing the cost effectiveness, although he doesn't call it so much this, between the two labels recommended by Biogen IDEC in their factor 9 product, and comparing that to the same kind of strategies with a standard factor, which obviously for factor 9 would be Benefix. And you can see here that if we have strategy 1, we will be saving, if you like, 52 infusions each year. We will be sparing the patients 52 less infusions each year because of the improved PK. If we go to strategy 2, we can spare another 15 infusions. We can spare 67 compared to the baseline, but only 15 more compared to strategy 1, and we will be spending quite a lot more money. And in fact, the premium cost in dollars, American dollars, per infusion saved, the premium cost of strategy 2, or rather label 2 to label 1, is about $14,000. Now, okay, we would like to spare the children as much as possible more injections, but are we ready to pay $14,000 each injection saved? Remember, we are not talking about efficacy here. We are not talking about the patients bleeding more. We're simply saying that they get infused at a lower frequency. And in this instance, it's a slightly lower frequency. We avoid 15 infusions. But for each infusion that we avoid, in terms of patient convenience, we spend $14,000. That is what we need to think about. Very interestingly, in this editorial of Dr. Neufeld and his colleague, they proposed the use of not just one product, but several products on the same patient. And they, in fact, suggest that given that the products all have efficacy, why should we consider that we only use the longer acting or only use the standard product? And in this very interesting editorial in Haemophilia, what they do is they propose what they're doing in this center, that based on the overall pharmacokinetic profile, that they proceed to, over the course of a dosage progression using the extended half-life, they also introduce at certain points the standard product, depending on the clinical circumstances. Of course, they make the point that they are still studying patients and developing their protocols, but I think this is a very interesting concept because, as I said, we think that all these products work. And so, if we then consider why should we, throughout this cycle, every time use the same product, we can introduce the standard product in certain periods, like between 70 to 120 hours after the first infusion, and get exactly the same result. And incidentally, at a considerably lower cost. Because the other wonderful thing about these products is that they have introduced huge competition in the market. And the manufacturers of the standard products who do not have the extended half-lives are very willing these days to enter into negotiations with the reimbursement authorities and to discount the products. For many years, Benefix was what in English we call the only kid on the recombinant factor IX block. It was the only recombinant factor IX. Always very expensive. For 20 years, the recombinant factor IX was always the same price, always very expensive. These days, I happen to know that some jurisdictions are buying Benefix for less than half what they were paying 2 years ago. Wonderful thing, competition. Okay, now I'm going to leave the extended half-life products. I'm going to these new, what we call pharmacological approaches, using drugs which are not coagulation factors for their effect in manipulating other parts of the hemostatic mechanism. None of these treatments have been licensed. Some of them are in different forms of clinical trial. So basically what you've got here, you all know this, you are all experienced hemostasis people here. You've got the hemostatic, the coagulation mechanism, and wherever you see a box which is dotted, as you can see over here, these are the new therapies, and we will go over them in some level of detail. Here is a summary of what we have. We have an antibody against tissue factor pathway inhibitor. We have a so-called RNA interference agent. This interferes with the generation of RNA against the RNA which generates antithrombin 3. And we have a very interesting agent called a bispecific antibody to factors 9A and 10. And I'm going to first speak about this one because this has received the greatest attention. It is being developed by Roche, so everybody thinks that because it's from Roche, it's wonderful, and it is at some interesting advanced level of clinical development. The principle of this ACE910, or I can't pronounce this, emixuban, this is a bispecific humanized antibody, and it's very neat. What they do here, using genetic engineering, is they take the specificity against one protein, an antibody specificity against one protein, an antibody specificity against another protein, and produce a bispecific antibody which has the two specificities, one against antigen A, one against antigen B. In this instance, these clever people have produced an agent which is a bispecific antibody with a binding site against factor 9A and a binding site against factor 10. Now, you know very well that the job of factor 8 is to bring together, if you like, factor 9A and factor 10 on the phospholipid surface of platelets. Well, what the antibody does is it makes factor 8 redundant. It is in fact a bypassing agent for factor 8. And instead of factor 8 doing this job, you have the bispecific antibody which then brings them together. Now you might say, well, why do this? Well, first of all, when we talk about bypassing agents, the first thing which comes to our mind is inhibitors, and that's the first point. The second point is that, of course, this makes factor 8 redundant anyway. But why should we want to make factor 8 redundant? Because this is an antibody. This is not a complex molecule which you have to introduce intravenously. This is a monoclonal bispecific antibody, and you can introduce it subcutaneously. I remind those of you who are involved in immunological practice that nowadays we have subcutaneous immunoglobulin to treat immunodeficiency patients. So this is a very, very sexy development. As to whether it is going to work is another matter. We will see some data, but that is the basic principle. Now, there's been about 3 papers, including this very interesting paper in the New England Journal in May of this year. The same issue of the New England, which had the CIPID study, they had this interesting paper. Now, these are relatively small numbers of, I think, Japanese patients. The basic science was done in Japan. Very clever people. Basically, what we've got here are 3 different dosages, cohorts with the different dosages. The cohorts are quite small. You will see the numbers in a second. So 0.3 milligrams, 1 milligram, and 3 milligrams per kilogram. The highest dose is 3 milligrams per kilogram. In other data, which I haven't shown here, they titrated the effect in terms of the coagulation via the APTT, and they titrated against equivalents in factor 8. What I mean to say is that 3 milligrams per kilogram gives the same effect as infusing to a peak level of factor 8 of 30% of normal. Keep that in mind, 30% of normal, okay? That's the biggest dose. it's very difficult to envisage a dose bigger than that. That's a hell of a lot of antibody, okay? This antibody is deposited into the subcutaneous space. This is subcutaneous infusion, once weekly injection. So everything's coming together here. Longer half-life, if you like, more convenient, once weekly, subcutaneous, all right? No portocats, nothing which can result in infection and so on, and an equivalent of 30% of factor VIII. And here are the clinical results so far. So very few patients, okay? Each cohort has 6 patients, and I'm not going to get into this, but there are many questions to be asked about this paper. But basically you can see that at the highest level you can get for patients without factor VIII inhibitor, in other words, patients who have normal antibody status but are haemophilia, an ABR with the prophylaxis of about 4 compared to 8 with factor VIII prophylaxis in this patient, only 1 patient shown there. And if you like, with the inhibitor patients, we have here a comparison between no prophylaxis and the agent prophylaxis, going from 40 ABR, therefore this was a patient on-demand, to 4.3. Good results, but very strange data. Why only 1 patient here, and why 1 patient here? And why show this data from cohort 1 with the lowest level, which basically doesn't really achieve much for the patients without factor VIII inhibitors, but does achieve with the factor VIII inhibitors? Very curious that you get better results with the lower dose with inhibitor than you get without inhibitor. Biologically inexplicable. So although it is a New England Journal paper, and although the agent is very interesting, and I'm sure we'll hear a lot about it over the next few years, we still have a lot of questions. Let's talk about the other antibody, which is this monoclonal against tissue factor inhibitor. Basically, you can see the mechanism here. We have the tissue factor inhibition pathway, which you can see over here. This is the normal Kunz type inhibitor with the domains which interacts with the factor 10A and the factor 7A to inhibit the pathway. The antibody is simply an inhibitor of this. So this, if you like, is treating hemophilia through a prothrombotic agent. It's as simple as that. This is a prothrombotic agent. It's important to keep that in mind, because when we look at the data, interesting things start to come out. First of all, look at what happens here, comparing the infusion intravenously and subcutaneously. There's a very interesting difference in the PK, as you would expect. So the idea again is that we will get subcutaneous infusion, and you can see that we can get a peak at this highest level of dose of about a steady state of about a week to 12 days. Pretty much what the other agent achieves. But this is very interesting and, in my opinion, quite worrisome. Look what happens to the D-dimer levels. We can see with these levels of dosage, high increases in the D-dimers. In my opinion, this is concern. This is of concern because it is a prothrombotic agent, and people must not run away with the idea that hemophiliacs cannot get thrombosis. I noticed Dr. Faranic just come in. They can, and although so far we haven't seen any problem, the actual data is still very, very low. So keep an eye on it, but I'm not very happy about this one, and I'm not very happy about the other one, although, and this one is more advanced. This is the interesting RNAi approach, in which the RNA inhibitor to the translation product of antithrombin 3 gene is introduced in order to effectively cut down the amount of antithrombin 3 generated in these patients. In that way, again, providing a pro-thrombotic stimulus to balance the lack of coagulation generated by the hemophilic state. You can see the situation over here as they titrate the patient in relation to the levels of antithrombin 3 which are achieved with the different dosages. And John Passy from London presented this data at the WFH meeting in Orlando, and basically you're seeing here the relationship between bleed events and the level of antithrombin 3 lowering which is achieved. So when lowering the AT3 level by 75%, that particular slice of the cohort got an annualized bleeding rate of 5. Obviously, well, maybe not as obviously, as the antithrombin 3 level was lowered to a lesser extent, you got higher levels of bleeding. So 2 points here. ABR of 5, we're not happy with ABR of 5. We're spoiled now. We want much better ABRs. I'll make the point again in a second. But the other point is, I don't know, lowering the antithrombin 3 level by 75%, okay, they've got haemophilia. But just think about the consequences of lowering antithrombin 3 to anywhere like that level in normal individuals. In my opinion, this is interesting, but I cannot see the justification when we have got such excellent alternative therapies for going into this kind of approach. And I hope that my former profession of regulators are suitably skeptical and will demand long-term studies for safety. And I showed you before the dimer results with the other agent. So overall, ladies and gentlemen, in relation to all these new approaches, we have now a reasonably good level of data on what they actually do, and many of them do not give us really the kind of thing which we want to see in hemophilia, which is as much as possible an annualized bleeding rate of 0, because of the considerations I outlined earlier in relation to joint damage and subclinical bleeding. So I think that we are still some way ahead. A way to go. I want to make a couple of comments about the possibility, again, relating to the important issue of inhibitors, the possibility of manipulation of the immune system. You have seen this part of this slide before. The anti-factor VIII immune response, the binding to the antigen presenting cell, subsequent activation of the T cells, expansion of the clones, and generation of B cells and antibody. Well, there are good theoretical reasons for thinking that the manipulations which we have discussed at the molecular level of these extended half-life products can actually result in immune modulation which is favorable to the suppression of inhibitors. If we look at the FC factor VIII, for example, by the FC receptor binding to the FC portion of the fused molecule binds to the FC receptor on the antigen and the B cell itself, you can see that you can get tolerogenic antigen presentation and suppression of the generation of antibody, and the same thing, although in a different mechanistic sense, can occur through having pegylation. We can have again immune ignorance and the suppression of the generation of antibodies, and even if the antibodies are generated, we can get some level of suppression by the PEG, and this is starting to look as if it is really interesting. This is data from a mouse model in which the mice were tolerized with the vehicle prior to the treatment as well as with the factor VIII FC product. They were subjected to this and then subjected to factor VIII immunogenic stimulus, and wonderfully the mice which were tolerized with the fusion factor VIII product showed a very small, much lower level of inhibitor development. You might say, okay, what mice and men? What about men? We have data. This is a very interesting paper, just this one patient, but in subsequent conferences, I think ASH last year, and also at the WFH in Orlando, we saw a small patient series. Here is a patient, started with a standard, this is a standard B domain deleted factor VIII with immune tolerance. You can see the antibody titer increasing. Switched to the alcohol, the FC fusion factor VIII, and look what happens. Okay, I mean a standard time course, a long time, but we get a much better response in the ITI. So this is a small piece of data, but backed up by the hypothetical benefits. I think this is very exciting, and this may turn out to be the reason why we actually will seek to prescribe these products. Nothing to do with half-life, nothing to do with infusion frequency, but if we can show that these products are less immunogenic and are able to tolerize better than the standard products, then all bets are off, as they say. A very quick summary of the gene therapy situation. for both factor VIII and factor IX. In relation to hemophilia B, you all know that we have had successful in inverted commas, conversion of severe to moderate to mild hemophilia B through gene therapy in some patients. The efforts continue, and several trials are underway, and results come out at a respectable pace. And it is the case that although the levels of factor VIII or factor IX expressed are still modest, no patient has gone from anything like more than 0 to maybe 5%, so conversion to, at best, a moderate to mild phenotype, but yet we have had some levels of success. Up till recently, the same level of success was nowhere obtained with hemophilia A. Very nice data on mice, but in human trials, successive episodes of failure. And then, astonishingly, in Orlando, out of the blue, BioMarin reported their gene therapy trial, still not published, but reported their gene therapy trial using their particular agent. And I mean, we were astonished. I went to the session just to pass some time. I didn't expect to see this data. It was not in the abstract, it was nothing. It was a so-called late breaking. And this was some interim data on their phase 1/2 gene therapy trial of their agent, BMN 270. It's with an AAV5 vector. And they seem to have, according to the presenter, who again was John Pazzi, to have hit the jackpot, because in some patients they achieved as much as 50%. In fact, there were 4 patients who developed super levels of factor VIII, more than normal. 2 patients had levels above 200%. You start worrying whether they're going to get thrombosis rather than hemophilia. So this is very interesting, okay? We await the publication and further data with interest. I also make the comment that BioMarin, 6 months ago, looked as if it was going to go bankrupt because of this development. So they hit the jackpot just in time. And we shall see what happens. So if I can conclude by reflecting, we are very excited, as I said, compared to the situation 30 years ago, where we just had a few fairly basic, low purity, sometimes unsafe plasma products. We now have a plethora, a very wide range of molecularly modified recombinants, and this is the real promise of the recombinant revolution, that we can, if you like, improve upon nature by doing these manipulations. And most of the attempts have come about by post-infusion kinetics being improved. Well, this has certainly given us, I think, the story with factor IX is definitely correct. And let me remind you, not to waste time, I won't go back to the slide, but if you look at the pharmacokinetics of the most successful molecule so far, which is the Novo Nordisk pegylated factor IX, you will say to yourself, as I do, why do gene therapy? If every 10 days the patient can achieve a normal level and maintain it way above the trough for the next 10 days with a simple single infusion, why substitute this for gene therapy, which so far at the most gives 5%, and for which we have relatively little long-term data in terms of safety, except that we do know that it is somewhat hepatotoxic. This is a very important consideration, I think, for hemophilia B. For hemophilia A, we have to await the possibility of getting modified von Willebrand factor as a carrier for the molecules. In the meantime, I am skeptical about the marketing claims of the current longer-acting factor VIIIs. Now, as to whether we take these on, depends, as usual, on money. The fact of the matter is, as I have shown you, that in the rich countries, these are being proposed as very expensive products. There is no country yet which has reimbursed the products very strongly, except the United States. And we await with interest, especially Germany, what Germany will do generally. The reference price for Germany translates into Europe. The Germans never really lost the war, they just won it in a different way. And therefore, we await with interest what will happen when the hard-nosed health technology assessment body of Germany, the IQWiG, will assess these products, which they will do over the next few months. In the meantime, it depends on the price and whether we can use the personalized treatment to actually fit these products in a comprehensive way in a full therapeutic protocol. The non-factor-based therapies are interesting. They offer potential advantages. The subcutaneous mode of delivery, which is made possible by the humanized antibodies, the monoclonals, is obviously very attractive. But I draw your attention to the fact that so far the most developed product, which is the ACE910 from Roche, can only achieve 90%, 30%. Therefore, surgery, substantial trauma, and so on will require factor replacement. And remember that when you use it for inhibitors, you are not actually tolerizing the patient. It is another bypassing agent. So if the patient, let's say, is on the bypassing agent and needs rapid increase of factor VIII to cover an emergency, there's going to be a problem because the inhibitor is still there. This is not a substitute for immune tolerance induction. Important. We need more safety studies. As I said, in situations of surgery, we do have doubts as to whether these products can cope. And that's not just a question of long-term, but even in their intrinsic properties. I finished the talk by reminding you that 70% of the world of the patients with haemophilia are unable to access even cryoprecipitate, let alone factor concentrates, and let alone these very nice scientific developments. So I would hope that all our efforts in this room and in this community continue to try to increase access for that proportion of the world's population. And since these are my last words at this conference, I would like to thank again the various people who were involved in getting me here and involving me. But I want to start my thanks by thanking the two translators, which have worked very hard, purely for myself and Dr. Falain over here, and have provided really my best experience in terms of this kind of translation in all the years I've been doing this. Thank the organizers again, and